Hi, welcome everyone.
Hello.
All right, should we give another minute or two for participants who are still joining us? Welcome everyone. We're going to start in just another minute or two. Let's wait for a few more people. All right, still a few people trickling in, so maybe we'll just give it another minute. Okay, I think we can start now. I'll start by introducing myself, and then Adi, you can introduce yourself as well. I'm Batsheva Maslow. I'm a reproductive endocrinologist. I'm starting with the Reproductive Medical Associates of New Jersey group next month. And I have a long history working with Nishmat. I am the medical director of the North American Yoetzet Halakha program, and so I've worked very closely with Nishmat, and I come here with a large fertility patient population, as well as being available to answer questions to many of the Yoetzot and others who have questions at where the fertility world of medicine and halacha intersect. And so that's what we're hoping to accomplish today, to answer some of those questions that you've had, that you've sent to us beforehand. And feel free, please, to ask some questions in the chat, and we're happy to answer whatever we can. And I'll turn over to Adi to introduce herself.
Thank you, Batsheva. Hi, I'm Adi Bitter. I'm a Yoetzet Halakha. I live here in Jerusalem. I've been a Yoetzet for over a decade, thank God, and I've been answering on the hotline, well over a decade. I've been answering on the hotline for around a decade. I feel very privileged to have been part of the Melavot Poriyut training program, where Nishmat has really given us a really incredible multi-year opportunity to really delve into the halachic, medical, and psychological elements of what goes into fertility challenges. I'm one of the Melavot Poriyut fertility counselors that works with couples who turn to Nishmat. And I feel privileged to have this opportunity. I think that a lot of times that question of like the intersection of the medical and the halachic is something that people dealing with coming into this world of fertility challenges are really wondering about. And this is a great opportunity. I feel privileged to have the opportunity to be here together with Batsheva, so that we can try to give a more holistic approach and answer to the different questions that you have.
Okay, so why don't we start? Feel free at any point to put in questions in the chat, and we'll start answering some of the questions that we received in advance. So some of the first questions, several of the questions that we got was about how to know when to see a fertility physician or get a fertility workup. Do you need to ask permission from a halachic standpoint? And what kind of guidance should you seek, both medical and halachic, before doing that? So I'll start a little bit on the medical side in terms of when to see a fertility specialist. There's a variety of reasons, and in the United States here, we sort of kind of generally say that if you've been trying for a year, where you have regular cycles, and you are under the age of 35, if you've been trying for a year, that's usually the first, the kind of step at which you should at least see a physician, whether or not it's a fertility specialist or your OBGYN. And if you're under 35, that after 6 months. And the reason being that there's, sometimes over 35, you should see a physician at 6 months. The reason being because there are situations that might be more limited in terms of your options for treatment as women get older. And so you want to be able to jump on those opportunities if something arises. That doesn't necessarily mean that you have to do some kind of treatment after 6 months. Other reasons to see a fertility specialist sooner than that would be if you're not having regular cycles. So it's one of my pet peeves. I have women who come to me or like, I've been trying to conceive for a year. And I say, when was your last period? And they're like 10 months ago. So that's a reason to be a little bit more aggressive. And again, it doesn't need to go straight to a fertility specialist if that's intimidating or unavailable. Certainly the first place you can stop is your OBGYN's office. And then really any time that you think there might be a reason to be more concerned than the typical person. Again, it's normal that it may take several cycles to conceive, but if there's something in your medical history or your partner's medical history, that's always a reason to at least start the conversation. Hadi, any insights?
I would also just add that something that I think is not necessarily on people's radars is that, as much as from age 35, there's kind of a steep, I mean, I'm not a medical professional, thank God, much of it is, but as much as from 35, there's kind of like a steeper decline in terms of women's fertility. Really from age 30, women's fertility is on somewhat of a downward headed slope. And we do live in an era where there's a lot of different attitudes and approaches about, when people want to begin their families. And I think that sometimes women aren't given like the full picture in terms of, people, let's say, opting into social egg freezing for purposes that are not medical. When they do have found their life partner and are choosing to postpone having children, I'm not sure that people always get the full picture, like about the ramifications on a woman's physical and mental health of choosing by choice to push off having children until a later point. And I just think it's worth it for women to know so that they can take that into account in terms of like their family planning. I would also say that before seeing a fertility specialist, and obviously different strokes for different folks, but I think that for women to really, like, I think for women to have a sense of like what's going on in their own bodies and have a good understanding of their own cycles and what's going on is just a helpful thing. Well before even people cross that the line of like, am I having a fertility issue or not? I think as soon as people are, as soon as having kids is on people's radars and they have a life partner with them to have those kids with, I think just women knowing how their bodies work is we live in an era that we're privileged to live in an age of information where we can find out so much about so many things. And I sometimes find it interesting when women who have doctorates and are clearly very knowledgeable don't really know so much about what's going on inside their own bodies. And I do think we owe it to ourselves to educate ourselves about how our cycles work and what's going on, just basic things that our body conveys to us about fertility. A book that I'm a fan of in terms of giving people good background information in a DIY type of way is Taking Charge of Your Fertility by Toni Wexler. And I've encountered religious people who don't like the title of the book because they're like, well, God is in charge of our fertility. But it's true, God is in charge of our fertility, but God said that we're God's partners in creation, and knowing, like, doing our part from a place of knowledge and reading our own user manual, I think is, certainly a step in the right direction. I know other people who aren't crazy about the book from the religious world because the author is not necessarily coming with the same religious sensibilities that we have surrounding issues of sexuality. But I think if people are able to kind of put those narratives aside and kind of take the fruit of really understanding how a woman's body works, I think that really makes a huge difference for women, both in terms of sometimes, figuring out things on their own. Sometimes people do want to actually go to a fertility awareness method educator before seeking out, figuring out what's going on their own in their body, so that when they do if they do find the need to turn to the medical establishment, that they do so with so much more knowledge. And from what I've heard from women who I've worked with, doctors are generally very grateful when women come in, like, knowing either that they don't ovulate or that they do ovulate but have a really short follicular phase. And these words might sound like Greek, but for a woman to go into a fertility doctor knowing that language and having a sense of like what might or might not be working, not only helps, I think, with treatment, but also helps the woman really feel like a certain sense of empowerment and ownership in terms of the situation, as opposed to feeling like she's kind of like dropping her body off for someone else to fix her. And considering how much research there is about like the role of mental health and stress levels in terms of fertility outcomes, I think anything women can do to kind of feel a little bit more empowered and involved in the process is something that can only be helpful.
And thank you, Adi. I would second pretty much everything you've said. And one of the things I do, and one of my specialties is seeing single women who come to me for freezing their eggs, or sometimes whatever it may be, for fertility preservation. And education is a huge part of that. Understanding and educating ourselves about what are the powers of our reproductive system and what are its limitations, and where it might where are its strengths and where it might need some assistance. It is really an important piece of sort of all of our lives, and one I would continue to encourage everyone here to pursue. The next question that came up in the chat was about testing, fertility testing. So often, as part of the fertility analysis, we look at a variety of different things that may lead us to understand what's going on. And one of them is a semen analysis, testing the sperm. This can raise some questions from a halachic standpoint. So somebody is asking, do we need to ask permission in order to get a semen analysis? So Adi, do you want to start on that? And then I can tell you what I've done with some of my patients in the past.
Sure. Okay. So the reason this even comes up as a question is because, and without pulling up a source sheet and getting into all the details, there is a concern within Judaism of hotza'at zera levatala, basically the notion of like wasting sperm or semen, and the question of how exactly that's defined and what's considered levatala is subject to debate. It's clearly not just connected to reproduction, because when a woman is pregnant, let's say, we're not concerned at all that a couple's sexual activity is something that might be levatala. It generally is defined as as long as like sexual intimacy is happening in a way that the couple is really in full contact of their genitalia, that type of bonding experience of not having physical barriers when the couple is together, that's considered like a context in which we're not concerned about the notion of levatala, of going to waste. Going to waste doesn't mean a baby isn't going to be born from this. Going to waste means like we're not in an intimate type of connection where there really is full contact. Now, in terms of gathering a semen sample, on the one hand, when this sample is being collected because this couple is trying to have a child, and the most normative understanding of levatala is like, oh, well, it's just going to waste. Well, here it's not going to waste. It's going to try to help this couple have a baby. That being said, the way the sample is collected is something that could end up being an issue in terms of, generally, for the sample to be collected, there can't be full genital contact between the man and the woman. And then there's a separate halacha concern, just in terms of also just how a sample would be collected, meaning would manual stimulation of the man to remove semen on his own be something that would be acceptable or not? Because even once we get over the halachic hump of hotza'at zera levatala, because we recognize this is not levatala, we're really doing this in order to have bring a soul into the world, there's still that question of how to go about it, and the notion of an interpretation of lo tinaf. One of the Aseret wrote, it connects somehow to an interpretation that the masturbation, or the man manually stimulating himself to ejaculate for the sample, would be considered problematic. So in light of the fact that there are those two kinds of question marks, historically, at least in Israel, where doctors have encountered religious people who are reluctant testing the male for those reasons, there was sometimes this movement of like, okay, let's do everything we can first to the woman before we do anything to the man, in terms of working them up in terms of fertility analysis, including invasive things to the woman, not just blood tests, but also other types of diagnostic tests to check for blockages, etc. But considering the fact that statistically, based on today's research, male fertility is on a pretty relatively steep decline. And if a pie chart of infertility issues, are they coming from the woman or from the man or from both, it ends up being pretty much 50-50 at this point. So considering those statistics, along with Nishmat's posthumous understanding of the halachic issues, Nishmat's halachic advice on this issue is that men may begin at whatever point it's determined that it is medically appropriate to begin fertility screening to see what's going on, that it would be completely appropriate for the man and the woman to start at the same time. It's not necessary for the woman to do everything first. In terms of exactly how the man is to procure the sperm, so the notion of, I think also just for every couple is different. And considering the fact that every couple is different, there isn't Nishmat doesn't really have like a one size fits all cookie cutter approach to like sperm collection for the man. And considering the range of halachic opinions out there, there really is room for a lot of different options. Some couples feel like if they, that being, collecting the semen in a condom, but in the context of intercourse, of sexual intimacy, is something that both halachically is closer to that place of sexual intimacy that would not be considered levatala. And of course, we're talking about a condom that is a sterile condom that does not have spermicide in it. Sometimes that sperm needs to be collected while the woman is nida, meaning depending on how her cycle works out. And if the woman is nida, so that's not even an option. So even though sometimes couples may prefer that, both emotionally and halachically, when it's not an option, then for the man to collect this sample on his own is also considered acceptable. And again, like everyone has their own, I'm not going to call it baggage, but their own history and their own narratives, their own perspectives and feelings about these things. And they're very personal and often very sensitive. And for the couple to figure out kind of what's right for them, and the Melavot Poriyut at Nishmat are always available to have these types of conversations to help couples kind of figure out like what their options are and figure out what would be most comfortable for them. But yeah, both like timing, we would say men and women can start with their screening at the same time, if that's what meaning really based on whatever the doctor says. Sometimes the woman comes in with like PCO, like a whole list of reasons that seem like these might be the reasons they're having difficulty conceiving. And from a medical perspective, they don't feel like they need to work up the male yet. But as soon as the medical system feels like, okay, it's time to see what's going on with the male, so then halachically we don't have any concerns with that. And in terms of the technicalities of the semen collection, again, a range of opinions, and there really is room for generally what works for the couple. We would advise couples to kind of be in touch with someone, some type of halachic guidance, to kind of just help them navigate and give them more information so that they can feel more empowered and knowledgeable as they go through this journey.
Fantastic. I will say in practice, I've seen exactly what Adi described, a very wide range of how we can navigate some of these sensitivities and issues and still be able to treat and test couples appropriately. So I have a very, very wide range of patients, some obviously who are not Jewish, but even within my large Jewish population, I have those that are sensitive to some of the halacha, those that are well within sort of a ultra-Orthodox right-wing Hasidish community where there's a lot more concern, not only about the halacha, but a lot of stigma related particularly to male infertility. And there's a lot of conversations that go around the testing and the treatment that involve collecting a sperm sample. But I will say, part of this is having a conversation with your physician, and having a physician who's sensitive to these issues is helpful. And so, when I start thinking about this and I am engaged in a conversation with my patients about some of these sensitivities. So the first is a semen test, when we're talking about testing, is it necessary right now? In a situation where a woman is coming to me and she hasn't had a period in 15 months, there's a very valid medical justification for treating that issue first before going down the road of needing a sperm test. Now, there are those who feel like we should just test everything all at once. But in my perspective, if this is a young woman and giving 2 to 3 to 5 months of regular ovulatory opportunities to conceive is not going to significantly impair their ability to ultimately conceive if we find some other problem down the line, that's something that I will often do. And so are there times where we then induce ovulation and 3 or 4 months later they have regular cycles and regularly timed intercourse, and then we discover that there is also a male factor? Absolutely. So we have to keep our minds open, but it's often in these circumstances where there is a lot of sensitivity and a lot of complexity around collecting a sperm sample, it sometimes does make sense to do a little bit of treatment for something more obvious. Now, if you have a young couple, or even not such a young couple where they have regular cycles and we would anticipate in every other circumstance they would be able to conceive, that's a couple in which I would want to test the sperm sooner rather than later. And then I will usually press a little bit in terms of testing. Now, in terms of collection, there are a variety of ways in which the sample can be collected. The most common and the most sort of standard is manual stimulation, and the man produces a sample on his own that allows for a pretty clean, not so contaminated sample, and can be done kind of at any time. So there's a lot more flexibility, but obviously that's can be the most complex and certainly has a lot of sensitivities and, like Adi said, a lot of narrative that comes along with that. I have a fair amount of patients who are collecting samples using a collection condom, and I will echo what Adi said. It needs to be a special condom. It cannot be the one that you just pick up at the grocery store. I've had, unfortunately, several patients who have done that, and then the sperm is all dead when you look at it. So it has to be a special collection condom. Usually the doctor's offices have them available. You actually can order them on Amazon here in the United States. I don't know about in Israel, but they can get them. Some people feel more comfortable poking a small hole in the collection condom, so you feel like at least if there is some sperm, it can make it through the hole. And I usually will tell people to use like a safety pin. It's not really going to harm the sample significantly. And granted, from a halachic standpoint, if this is somebody who's concerned about the halachic ramifications, that's going to have to be done through intercourse when she's obviously not in nida. The last way that I collect, and is, I would say, the poorest method, but sometimes the most acceptable for couples who are really struggling with getting a sperm sample, is to do what we call a cup collection. Where we tell a couple to have intercourse the way they would normally have intercourse, and we give them a sterile cup, and we tell the woman to collect the discharge that comes from her following intercourse. And it's going to be all sorts of stuff. There's going to be semen in there. There's going to be vaginal discharge. There's going to be there's going to be sperm cells and skin cells. And so it's the most contaminated specimen. But often that's a good way, if someone's really uncomfortable with producing a sample, that at least we get a first look. So if we look at that sample and it's got all sorts of stuff in it, but we see millions of sperm swimming around, then we can feel pretty reassured that there isn't a major male factor here. However, if we look at that sample and there's no sperm, or very few sperm, or the sperm are dead, or there's some problem there, that would then prompt us to do another test with a better collection method. Because we never really know, is it the sample that's really poor, or is it that the collection was very poor? So those are kind of the 3 methods, I would say, for testing. When we're talking about treatment, there are a variety of treatments in which we would want a sperm sample collected. So either for an IUI, which is an intrauterine insemination. This is where we would take a sample of sperm on the morning of ovulation. So either we're giving medication or we're monitoring the ovulation, but we know the ovulation is about to happen. And we take a sample of sperm and we're going to concentrate it down so that we have a lot of sperm in a very little volume. And we're going to take a little catheter and place it through the cervix into the uterus, and deposit, hopefully many, many millions of sperm right near where the egg is going to be. Because when a couple is having intercourse, 90% of the sperm are swimming in every which direction, and only a very small percentage ever even get close to where the egg is going to be, which is why we have this redundancy. That's why there's hundreds of millions of sperm sometimes. Because you really only get a tiny amount close to where fertilization can happen. So with an IUI or an insemination, we're kind of giving the sperm a boost, a head start. We're moving it closer to the finish line. So that would require a sperm collection. And generally speaking, the cup collections tend to be not as valuable or not as effective because, again, it's contaminated and it's got all sorts of stuff. But in a real pinch, I've done it. But usually either with a condom collection or a manual collection, you're getting a better sample and have a better chance of success. The Other time that we collect sperm for treatment is with IVF, or in vitro fertilization, where we're going to use the sperm in the lab to directly fertilize the eggs. And this is where we get sometimes run into the challenge of the sperm being needed on a day prior to the mikvah. And sometimes what I will do is address this with my patients well before we even start the IVF stimulation, before we start the IVF cycle, to be a little bit proactive, and we can freeze a sperm sample in advance. So let's say before she starts, before she gets her period, when she's, Torah and she's been to the mikvah, they can collect a sample if they want to collect it with a collection condom. That sample, generally, assuming it's not a very poor sample, if it's a moderate to a good sample, can be frozen really without any issue, and it's not going to hamper the chances of success, generally speaking. Again, every case can be somewhat individualized, but that allows us to avoid potentially needing a new collection of sperm on the day of the egg retrieval, which sometimes falls before the mikvah. Not always, it doesn't always work out that way, but that's one way that, you can partner with your physician to try to work around some of these issues so that we're not ending up in sort of a panic mode on the day of the egg retrieval. And that's some of the things that I've done in my patient population in order to try to minimize some of the sensitivity and complexity around sperm collection. And we can be flexible to many, there is room to be flexible sometimes. Let's, kind of dovetail this conversation, since we were talking about collecting sperm prior to the mikvah, but what happens when someone is ovulating prior to the mikvah? So this is a question that I get, and I'm sure Adi gets a lot. What happens when you have a woman whose cycle, for whatever reason, is ending up where her ovulation falls before the mikvah, and so she's potentially missing her opportunities to conceive because by the time she gets to the mikvah, she's sort of out of her fertility window. Do you want to tackle it first?
Sure. Thank you, Batsheva. Okay, so yeah, totally a very common question. And sometimes the way that it was that Nishmat formulates this situation is ovulation before mikvah, which is just accurate. Sometimes people outside of the Nishmat will call it halachic infertility, and Nishmat's not so comfortable with that term because it's not infertility. You can't use the word infertility if there's no medical problem. Like if the only problem is that the couple isn't being sexually active at the time that she's fertile, that's not a fertility problem. And often it's not halachic, meaning very often it's not really halacha that's standing in a way. It's often people's understanding of halacha. Like a more crass way of putting it, it's not halachic infertility, it's halachic ignorance sometimes. Now, obviously not always, and there are exceptions, of course, where really, even when a woman is fully aware of the halachic options and has all the halachic things that she could possibly do, she's still ovulating before she goes to the mikvah. So that does happen. But I think that many women's ovulation is kind of around mikvah night. But often women are just not going to the mikvah soon enough. I encountered once in a refresher course that I was teaching a woman who is a nurse in a hospital, who by the time she took the refresher course, she had a bunch of kids, but she was recalling to me that toward the beginning of her marriage, they weren't conceiving right away. And she was like, well, I work in a hospital. I'll just walk right down to the IVF, stuck out her arm, stick me, like she was sure that she had a fertility problem. And the nurses there were like, Hamuda, like, sweetheart, like, don't like, why don't you first speak to some halachic authorities? And she, this was a long time ago, she contacted Machon Pua, and they said to her, well, what day are you going to the mikveh? And she said, well, day 16 from when I got my period. And they're like, day 16? She's like, yeah, well, I'm bleeding for 9 days. And then I wait my seven clean days, and I get to the mikveh on day 16. And they were like, whoa. Okay, so that's like the first thing that I think happens to many women, often from it really is a misnomer, this concept of Shiv'ah Nikim, the 7 clean days, which are a halachically necessary part of the process. But the word naki people think of it as clean in the physiological sense, like, oh, the 7 clean days, that means like all of the physiological remnants of my period are gone, and now I'm going to wait 7 days. Naki doesn't mean physiologically clean. It means like free of seeing things that are halachically problematic. Now that has ramifications in terms of two things. One is in terms of color. Things that are not considered halachically in the family of red, Nutella Adom, are not a problem. Now, which browns are considered red or not is something that people would need to consult with a Rabbi Yoetzet, like someone who has done extensive training and has a Masorah in terms of colors. But like things can be really like shades of brown, very dark shades of brown, like shades of chocolate, like all sorts of shades of brown that are often not a halachic issue. And a woman can be in her Shiva Nikiyim, her 7 clean days, like with bedika class, internal checks that are coming out with like all sorts of colors that are clearly physiological remnants of blood, but are actually halachically completely inconsequential, and they may as well be clear. So again, like, people do need to be trained, or check with someone who has trained in terms of what is or isn't a problematic color. There is a concept of women always get that same color again and again. Once they've asked enough times, like they don't have to keep asking if they're confident that it's the same color. But yeah, many colors are really totally fine. So I think that's one thing that often leads to women getting to the mikveh later than usual is waiting to start their 7 clean days, their Shiva Nikiyim, until really there's like absolutely nothing there. The other thing is that there can actually even still be red going on during the Shiva Nikiyim, because the whole point, basically the way the halachic process works, is that women need to wait a certain number of days. Then they do their hefsek tahara, which is an internal check that basically establishes that the red flowing part of the period has ended. And in normative cases where women's where women are not like trying to conceive and potentially missing their mikveh, like missing their fertile window because of when mikveh night is, so then we would generally, go with the lechatchila, the ideal halachic procedure of 2 following the day of the hefsek tahara internal check, 2 internal checks on each of the 7 clean days, as it says in the Shulchan Aruch. That being said, the Shulchan Aruch is very clear that in b'diavad situations and extenuating circumstances, and certainly women trying to conceive would fall into that category, that women can do fewer internal checks, like the hefsek tahara and the following day, day 1, is necessary, and the last day would be necessary. And obviously, this is beyond the scope to go into all the details of that, but women skipping some of the internal checks is something that's certainly possible. Now, on an internal check, any amount of red, if it's uterine, would be an issue. Whereas on a woman's underwear, I talk about blood like I talk about the weather, and I assume anyone coming to this conference might kind of be used to that, although I know there's sessions on all sorts of topics. So apologies if that's kind of surprising to you. Anyway, so if women do see blood on their underwear, so if the underwear is white, which it should be, again, in lechatchila normative situations, the underwear should be white during the 7 clean days. So then a ketem, a stain that's red, that's larger than a gris, which would be, a circle with a surface area of 19 millimeters between a penny and a dime, or between a 1 shekel coin and a 2 shekel coin in America or Israel. I know there are other countries, I just don't know all the currencies. So then once it's larger than a gris, so that would invalidate the count. But if it's smaller than a gris, or even if there are a bunch of stains smaller than a gris, so that would be fine. But in these type of b'diavad or extenuating circumstances where a woman is trying to conceive and she is still spotting, like the flow stops, but she kind of trickles red for a bunch more days. So once she gets that hefsek tahara without problematic colors, she would be told in such situations that she could wear colored underwear instead of white. And then that spotting, even though it's red, would not be halachically consequential. And I know that might sound like cheating the system, and I'm sure there's another section in this amazing Health and Halacha conference where they explain why that's not at all cheating the system, is the system. But yeah, basically the laws of spotting are fascinating. I find, maybe that's why I'm going to say halacha, but basically, if the red flowing part of a woman's period has ended, the chances are pretty good that she can be in her 7 clean days, even if they're not physiologically clean. Now, 2 other points. One is that normative Ashkenazi psak is to wait 5 days from onset of menstruation until doing that hefsek tahara, doing the hefsek tahara on day 5, and then doing the 7 clean days, which means that in normative cases, an Ashkenazi woman can get to the mikveh before day 12. If a woman has good reason to believe she's ovulating earlier, which parenthetically, I'll say, like, one way of ascertaining that is by doing urine dipsticks and kind of seeing when she ovulates, then checking for the LH peak, which is the hormone released in the body that correlates with the release of an egg. Although, if women are tracking their fertility using the fertility awareness method and even being aware of like that intense, like, egg white type of feeling within the vaginal canal, like a really like a wet sensation accompanied by like an raw egg white type of discharge that is basically dried up by the time the woman goes to the mikvah, and she's seeing that discharge toward the end of her 7 clean days. That's generally like an indication. Again, I'm not a medical authority, but at least according to the fertility awareness method, like, that's generally an indication of when a woman is most fertile. It's when her cervix is producing a type of like sperm food, essentially. It's like when the gates are opening up and the body's like, bring on the sperm. Now is when, like, it can kind of swim up and hang out in its sleeping bag until the egg will be released. And missing that fertile window, even if a woman's ovulation technical test might be after, that would be like, if a woman feels that wet sensation before she's getting to the mikvah, that would be a good reason to speak to a halachic advisor of sorts. So basically, if waiting until day 12 means that a woman is missing her ovulation, she's Ashkenazi and she has a short bleed, and again, from what I've seen, often women with shorter cycles, not always, but they often have shorter bleeds. So she's having a 3-day bleed. So to wait until day 5 to do her hefsek tahara when she's trying to conceive, if she's ovulating on day 11 and not on day 12, that's not really working for her. So the whole thing of waiting 5 days, as opposed to, again, beyond the scope of what we can go into here right now, but going down to 4 days is something that, again, for fertility reasons or other types of extenuating circumstances, is something that would certainly be an option. And like a quick call to Nishmat's hotline or making an appointment with a Yoetzet Halacha could help a woman kind of navigate that and figure out like her steps for the coming cycles. If a woman calls the hotline on like her day 6 of her 7 clean days and it's like, I just did an ovulation test and I see that I'm ovulating now, can I go to the mikvah? My heart goes out there, but like, no, the 7 clean days is really not optional. But the solution is to really start the 7 clean days earlier. And often between the halachic guidelines that day 4, and there are ways also of even doing it earlier than that if the bleed is over, again, without going into the specific details, but that's something certainly possible. Also, just from a practical perspective, I've seen that women, I've heard from others that I've kind of seen myself in women that I've counseled, that women who use menstrual cups as their hygiene method of choice to deal with their menstruation tend to concentrate the flow into the very early part of their period. A menstrual cup is like a silicone reusable kind of cup that women insert into their vaginal canal, similar to the way they would insert a tampon. Well, different and similar to a tampon in that it stays in the vaginal canal, but as opposed to absorbing blood, it collects blood in the cup. For some women, that sounds like, whoa, like, why would a woman be comfortable seeing collected menstrual blood? But really, like, blood is blood is blood. And the fact that we've become accustomed to seeing it absorbed in cotton, but not collected in cups, is really just a matter of like conditioning. And like, apparently from research I've heard, like 9 out of 10 women, at least what the companies say, 9 out of 10 women who have given menstrual cups like a 6-month try to kind of get used to it with the learning curve would never go back to anything else. So even other than questions of like getting to the mikveh sooner, fertility issues or otherwise, like, it does seem to be something that people like. I'm meaning everyone should do what works for them from a hygiene perspective, but it is something that I've seen does concentrate women's bleed into a much shorter window in the beginning, and enables women to start their Shiva Anakim much earlier. So before anyone goes and there are, Batsheva will now speak about like medical things that can be done to push off ovulation, but Nishmat feels very, very strongly that if there isn't a medical issue, that we should do whatever we can halachically to enable the women to get to the mikvah on time before we start dealing with medical things. Sometimes, though, there is also a medical issue, and something that I did hear from a woman here in Israel who deals with one of the more holistic ways of dealing with fertility. And Rashavi could let me know if this is true, that often if the woman is ovulating so early, sometimes the egg is not even necessarily like ripe in the sense like it's being released, but it's not necessarily so fertilizable anyway. So like there are certainly alternative Chinese medicine related ways that people will sometimes approach before beginning more tradition, like modern day interventions to push off ovulation. And sometimes there are recommendations of like give it, if this is someone's thing, like to give it 3 months of alternative medicines to see if they can kind of work out the cycle to be longer, because that kind of gives the egg more time to do what it needs to anyway. But then obviously there are medical solutions as well. But we'd for sure try on the halachic front to do whatever we can before heading to the medical front. And sometimes, people need, I think it's helpful for people to work, like to just recognize that patience is a virtue, because stress doesn't really help. And with these types of things, it sometimes is like a 1 month at a time of like, okay, let's try this and see if it works before we like go down, not down, but before we take advantage of another potential halachic leniency. But obviously if a woman is in her late 30s, so we wouldn't necessarily take that time. Yeah, gotcha.
Okay. Thank you. I think that's so helpful and can be really, an excellent opportunity for partnership between physicians and, halachic advisors, because it can be a complex issue. So when I see a couple and they suspect that she's ovulating for the mikvah, there's really two things that go in that I think about. One, is it that she's ovulating before the mikvah because her cycles are very short and her ovulation is what we call premature? She's ovulating very early. Or is it that she's going to the mikvah very late and she's bleeding for a long time? Now, Adi touched upon some of the ways of like halachic workarounds that we can use to try to help her get to the mikvah closer to ovulation. But sometimes there are real pathologic reasons why women are having these issues. So let's start with the one where she's bleeding for a longer period of time. So somebody having a 9 or 10 day period is not normal. And sometimes there are reasons. Maybe there's a polyp, maybe there's a fibroid, maybe there is something like pathologic, something going on in the uterus, either functionally or hormonally, that's causing that extended bleeding. And that's certainly in and of itself, forgetting about ovulation and trying to get pregnant, having a very lengthy menstrual cycle is a reason for a workup regardless. Sometimes I have women who are able to get a hefsek tahara, but then they start bleeding mid their shiva nikiyim and have to start all over again. That's also not normal. And sometimes there are reasons for that. Is that it could be hormonal. Again, it could be functional. It could be mechanical. There's fibroid or polyp. And I've had many, many circumstances where we'll find a polyp, the polyp gets removed, and the next cycle they have a totally normal cycle. We're able to go to the mikvah on time, and I've had patients get pregnant that way. So it's not always necessarily that there needs to be medications to alter the cycle. Sometimes there's something that's not related to the cycle that's bleeding. And that's causing problems. So that, when there's lengthy periods like that, it's often worth looking into, is there something that can be adjusted so that the periods are not quite as long so that somebody's getting to the mikvah earlier? Again, also being able to utilize a lot of the halachic tools that we just discussed. Sometimes it's what's more challenging can be when somebody has very short cycles. So ovulation will typically happen 14 days prior to the next period. And so somebody who has a kind of classic 28-day cycle, they're typically ovulating around day 14, day 13 to 15, let's say, right? And typically that falls right after the mikvah. Now, again, somebody who's having a super long cycle, let's say they have a 35-day cycle, they're not ovulating till day 21. And sometimes actually I run into, this is a little bit of a different issue, but I run into couples who are, they're being together, they're having intercourse right after the mikvah, and then they like take a break for a week. and they're not together that frequently thereafter, and they're kind of missing their ovulation for that reason. And sometimes, so it's just as simple as recognizing that you need to also be more active in the week following the mikvah if their ovulation is that far after the mikvah. But somebody who has, let's say, a 24-day cycle might be ovulating on day 10. And if you're consistently ovulating on day 10, but not getting to the mikvah until day 11 or 12, you may be unable to conceive because you're sort of missing your window. Now, ovulating on day 10 is also not entirely normal, especially if that's not something that you've always had. So there are a few women who have always had short cycles from the time they were adolescents. They've always had, 23, 24, 25-day cycles, and they're always ovulating on day 10 or 11. But certainly if you've had somebody who, a year or two ago, my cycle was 27 days, and then it was 26, and then it's 25, and now it's 23, that's concerning. And it's often a sign, it can be a sign of what we call diminished ovarian reserve, that the egg supply is declining. Now, we know that women's egg supply declines naturally as we get older. And when you hit a critical point of decline, you start seeing changes to the menstrual cycle. In a way, the period, or the brain, the communication between the brain and the ovary is working harder to try to push ovulation forward. And when it does that, the cycles start to overlap. They start to shorten. And so you start to get ovulation happening earlier and earlier, and the cycle's getting shorter and shorter. And so sometimes I will see a young woman in my office who's coming to me for quote unquote halachic infertility, and I end up diagnosing her with diminished ovarian reserve. And that can lead us down a road of a variety of different pathways, meaning we could say, okay, we're going to start with some halachic changes first, if those are available to us. We could start with some medical interventions. It could be that this is a young couple who wants to have a very large family, and she has a very low ovarian reserve, and maybe it makes sense to be way more aggressive and go straight to IVF so that she can bank embryos, and they can, there's a lot of conversations here that are sort of beyond the scope of this chat. But suffice it to say that a short ovulation, or a short period where ovulation is happening before the mikvah, is not always a halachic issue. And it sometimes is the canary in the coal mine for something more concerning that requires more intervention. And that does sort of go along with what you were saying about that woman who said that the eggs are not sort of ripe enough. There is some scientific backing to that eggs that are not stimulated for long enough, the cytoplasm, they don't have what we call cytoplasmic maturity, that the cytoplasm is not able to fertilize, to accompany the sperm on its way to fertilization. So even if they were able to conceive, even if they were able to have intercourse on day 9 or 10 around ovulation, sometimes they don't. And that's why I see couples who are not mikvah observant, or who are not Jewish, who have short cycles, who have infertility. And that's, again, sort of our flag to say, okay, wait, we need to look into this a little bit further. So, that's where these two issues overlap. In terms of treatment, I can't say what's in the the Chinese and what Eastern medicine's role of like what they utilize to regulate the cycle. But my first choice to regulating cycles from a medical standpoint is actually pretty natural, so to speak. I use a medication called estradiol. It's the natural form of estrogen that our body produces. It happens to be in a pill form, but it's actually just estrogen that our ovaries produce. And the way the menstrual cycle works is that the brain is sending a message to grow the egg because it senses that estrogen has dropped at the beginning of the cycle. And it will naturally sort of shut down that stimulation once estrogen starts to rise and when the ovary is responding by growing an egg. So what we do is almost fool the brain and fool the system by giving a low dose of estrogen for several days at the beginning of the cycle. And what that does is kind of put a pause on that stimulation for the egg to grow. So if you take it for a few days and then the menstrual cycle, the stimulation of the egg starts, you've delayed ovulation till after the mikvah. And this was a protocol that was developed by some Israeli doctors maybe 15 years ago. And it can be very successful. Again, it only will unmask if there's some other issue beyond just the timing. But if it's just the timing, this can be very effective. It tends to have very few side effects because the medication is the same estrogen that you're taking your body's producing in a very low dose. And so it can be a really simple, elegant way of of addressing this issue. And I've had lots of success with it. So I generally wouldn't do it for, 6 to 12 months, because if it's going to be successful, it will typically work within the first 3 to 4 months where you've delayed ovulation. If you're consistently delaying ovulation till after the mikvah and you're still not getting pregnant, that's usually a sign that there might be something else going on. And sometimes, look, everyone responds differently. Sometimes the estrogen is too suppressing and we have to try other things, and we can get creative with other medications, but we don't necessarily have to jump right to fertility medication or fertility treatment. But sometimes that's reasonable, especially if this is something that is going along with diminished ovarian reserve, where we know that we have to be a little more aggressive in terms of timing. And that's where it's worth a conversation with a physician, because every case is going to be a little bit different and there's going to be different options that can be utilized. And I think my biggest take home point from this is that if you think that you are dealing with this where you're consistently ovulating prior to the mikvah, don't just sit on it. It's worth a call to a yoetzet, to a halachic advisor, to a physician, whether that's an OBGYN or a fertility specialist, because it doesn't have to be something that you just sit with. There are things that can be done to try to improve the chances that you conceive without doing aggressive fertility treatment. Great. I have another question. Adi, do you have any questions coming in that you want to?
No, you're welcome to.
Okay. So one of the questions that came in, and we briefly touched upon this in the beginning, but maybe we'll talk about it a little bit more, is, how much would you suggest someone try diet or exercise or other types of sort of non-invasive methods of conceiving before seeking help? And the question is particularly for somebody who's not ovulating regularly, who's not getting regular periods, but I think we can expand it to discuss it for pretty much everyone. I will start with this and then feel free to chime in. But I would say, for number one, for somebody who's not ovulating regularly, yes, there are definitely ways that you can utilize exercise and diet and other techniques to try to induce ovulation. But they're generally very poor at doing so in a way that's predictable and reliable. So long-term, if you're looking at your long-term health and, wanting to increase your chances of having regular periods and ovulation over the next, 5 to 10 years, yes, there's a lot of really good lifestyle modifications that can happen. But if you want to get pregnant and you want to get pregnant now, there's very little that can be done in the span of a month or 2 or 3 that's really going to make a significant change. Now, there are times where it will happen, sort of the hallmark of something like PCOS or polycystic ovarian syndrome, or women who have ovulatory dysfunction where they're not ovulating regularly, is that they will ovulate every once in a while. It's just that it's hard to predict when that's going to happen. And when somebody's trying to conceive, it's challenging to have that kind of unpredictability. The whole thing is unpredictable to begin with, and you're adding some more unpredictability. So I would say this: there is no shame in getting assistance in terms of inducing ovulation. Again, does not necessarily need to be done by a fertility specialist. Lots of OBGYNs will initiate ovulation induction, and the medications that we have for ovulation induction are very effective and tend to have very few side effects. I know there's lots written about Clomid on the internet and terrible things and make you feel terrible. And to some women it does, but for many, many, many women, it has very few side effects and is very, very effective. So I would encourage somebody that, if you're not ovulating regularly and you're not getting periods, waiting the requisite year to seek help is often wasting your time, because you're not getting the opportunities to conceive if you're not actually releasing eggs. You're missing these opportunities. So it's worth getting, seeing someone sooner rather than later. And then, in terms of a broader scope for women and couples who are trying to conceive, again, lifestyle modifications are important. You want to be your healthiest that you can going into pregnancy. I would caution against kind of very strict calorie limitation and dieting. These tend to be harmful to pregnancy, meaning you don't want to go, your pregnancy doesn't care about your size or the numbers on your scale. They're, your body is looking at your sort of overall nutrition, and you want to go into a pregnancy healthy. And so women who are taking aggressive measures to lose weight, regardless of their starting weight, are actually hurting themselves in terms of going into pregnancy in a malnourished state. And so I usually caution against that. But generally, good diet and exercise and lifestyle modifications are very important. Certainly, we know that stress plays a role, but it's not the be all and end all. So I sort of caution my patients to not get stressed out about becoming stressed out. It's just a vicious cycle. But finding ways to cope with the stress is very helpful. And I will put in a plug here. We talk so much about women and lifestyle modifications. Lifestyle modifications are so much more effective and beneficial for men. So sperm is extraordinarily sensitive to environmental factors. Eggs women are born with all the eggs we'll ever have, eventually run out of them. So they are affected by time, but they're much less affected by our environment. They're very well protected. They actually don't communicate directly with our bloodstream. So there's very little that we as women can do that will directly affect our eggs. And sperm is like the opposite. Sperm is constantly produced every single day, and it is very, very sensitive to men's environment and their lifestyle. So things like smoking, alcohol intake, drug use, illnesses, exercise, weight gain, weight loss, significant shifts in weight, all of those things affect sperm, generally temporarily. But if your if you're trying to conceive and your husband or your partner is smoking, drinking a lot, not exercising, those are things that can actually have a tremendous benefit on your ability to conceive. And they take time because it takes about 90 days for new sperm to be produced. So, if your husband is could use some lifestyle modifications, the sooner you work on them, the better. And again, I would encourage women and couples who are having issues who are trying to conceive and it's not working. You don't have to sit on it just because someone told you have to wait a year. It is worth discussing either with a yoetzet or a physician if 6 months have gone by, or you have a reason to suspect that there's something else going on. Time is precious, and if there's an intervention that can be done because it's necessary, you're better off doing it sooner rather than later. And if it's just a matter of, okay, everything looks good, let's give it another 3 months, that's also very reasonable. I'll turn it over to you, Adi.
Thank you, Batsheva. Yeah, amen to all of that. I'll just say, meaning I see we don't have so much time left, but I just jotted down some associations as Batsheva was talking. First of all, generally, anyone who teaches kalot, I think part of the duty of a kala teacher is one of the first questions to ask the woman after getting a little bit comfortable is tell me about your cycle. And if a woman knows she has an irregular cycle, that's generally not a new thing. And I even when I teach 18-year-olds about these halachic topics, I always make it clear I'm not a medical professional, but that they should speak to a medical professional if they have an irregular cycle, because in as much as something like polycystic ovaries is an issue in terms of conception, it can also be an issue, from what I've heard from lectures from doctors, of just women's uterine lining building up and building up and building up because they have polycystic ovaries and they're not getting a natural period. So I encourage women to talk to doctors about their polycystic ovarian syndrome either way. Some doctors might recommend that every 3 months that the woman didn't get a period on her own to kind of induce a bleed. But again, I just think my place is just encourage women to talk about it. Now, if a woman is getting married when she's young and she knows she has polycystic ovaries or irregular cycles, so then if she's not pressured to get pregnant that minute. So as Batsheva said, women do ovulate periodically, even if they have polycystic ovaries. And sometimes, though not always, if they just catch that ovulation, that's all they need to do is to catch the ovulation. So as I mentioned earlier, learning about the fertility awareness method is something that can help women identify just from literally information at their fingertips of from their own bodies of like when they may be conceiving, ovulating, and that could be super helpful. And then like they don't necessarily have to be so stressed. Sometimes like newlyweds when they get married young are like, oh, like I'm not sure I want to get pregnant right away. But sometimes it's like, I think it's helpful because sometimes the default in certain communities, the couple's like, well, I certainly want to be on birth control right away. Well, if it might actually be pretty hard to conceive, couples might want to like think about that. Like if they want to go on birth control right away, because I've seen the couples who do go on birth control right away, they think the minute they go off, they'll get pregnant. And then it's like, oh yeah, I actually never had regular cycles since I started getting my period. And I've just been on the pill all along. So like kind of remembering that, God is in charge and we also do have to do our part, I think can be helpful. I will echo also like healthy lifestyles, I think are important for everyone. I think that unfortunately it's those who sometimes end up with the medical issues that end up being actually really motivated to really take care of themselves. But ultimately, if we remember that like God gave each of us like a unique soul with a unique contribution to make in this world, like we're not angels, we're humans. God put us in bodies for a reason, and it's our duty to take care of our bodies so that we can really shine like our divine light into the world. And I think that whatever people are going through when they are well in terms of healthy lifestyle, eating well, exercising, sleeping, communicating, dealing with their mental health, be it with mindfulness or something else, they really can just weather whatever challenges they're dealing with much more grace and wellness. So
great. I think that's awesome. And I will touch just briefly upon that since you brought it up about adolescents and young adults having irregular cycles. I see this so frequently, and I get calls, from young women or from their mothers or their sisters about it. So, and it is a little bit of one of my professional pet peeves when like someone tells like a 14-year-old that they have PCOS and that like sets them on a path for the rest of their life. So, PCOS is a very particular diagnosis. It's called polycystic ovarian syndrome. There's a very particular set of diagnostic criteria that qualify for PCOS. One of them is not getting regular periods. The other is having a high ovarian reserve with lots of eggs, either on ultrasound or on a blood work test called an AMH. Now, young women, and particularly adolescents, will often have those two things, and that's not related to this other diagnosis of PCOS. So it is actually super common for adolescents, so women who are like 16, 17, 18, 19, even into their early 20s, have irregular cycles, and that doesn't necessarily mean they're going to be irregular for the rest of their lives. It can take sometimes 8 to 10 years after menarche. So menarche is the first period. It can sometimes take 8 to 10 years after menarche for a regular cycle to induce, to actually sort of get a pattern. And so it's very, very common. The challenge is that we don't often, in my general population, I don't often have 19, 20, 21, 22-year-olds who are trying to conceive. And so many of them either don't care that they have irregular cycles or they've been on birth control pills to regulate their cycle since they were 15 years old. But when I have young women who are trying to conceive, it can be very disconcerting. Like they think that something's wrong with them. And I'm trying to tell them that nothing's really wrong with them, but they don't want to wait 5 or 6 years to see if their cycles become regular. And that's, again, where, there's probably no amount of diet or exercise or lifestyle changes that are going to fix that, because it's ultimately a maturity aspect in that communication between the brain and the ovary. The hypothalamus that regulates the cycle, it takes time to mature. And sometimes that takes into the 20s. And so that's where ovulation induction medications can also be super effective and super helpful. And just because you needed them for your first cycle, for your first baby, does not necessarily mean that you'll need them for every subsequent pregnancy. And I've had so many patients who have needed assistance for ovulation induction for their first, sometimes 2 or 3 babies. And then all of a sudden they start getting regular periods, either in their late 20s, sometimes in their 30s. And they don't believe me when I say like, no, now you can just try. You don't necessarily need help. And sometimes they're able to conceive without any issues. So there is this continuum, and it's important to kind of recognize where things go and fall. And again, that's part of the education and understanding about like what our bodies are capable of. And it's important, like events like this are very important to be able to kind of answer some of your questions. Hopefully we've been able to get out some information, both from a medical standpoint, from a halachic standpoint. I hope that you all found it helpful. I'm sorry if we didn't get to everybody's questions, but our time is basically up, and this was really great. Thank you, Adi, for joining.
Thank you,
for having us. I have a pretty active social media account. You can find me on Instagram. I'm at BLMaslowMD. So if you have questions that we didn't get to today, and you want to reach out to me, I cannot answer specific medical questions individually on social media, but if you have broad questions related to fertility or fertility and halacha or the intersection, I'm happy to address them, and I'll put my handle in the chat.
Right. And I will say that I'm not on any social media. I like having kind of like a quiet existence, but I am very, very happy to help women. And if you email me at adbitter, you see my name on the screen, adbitter@gmail.com. I'm very happy to like make a time to talk and address whatever is going on for you. Really besimcha rabba, even though I don't have social media.
All right. Thank you, everyone. Take care.
Thank you. Have a good day and night, and enjoy the rest of the conference. And may everyone be blessed to really be able to bring children into the world in good health and happiness at the right time. And so that should be just a peaceful journey.
Amen.